والآن مع كلمة السيد رئيس فرع طب الأطفال الأستاذ الدكتور محمود فوزي الصراف المحترم.
بسم الله الرحمن الرحيم. الحمد لله الذي علم الإنسان ما لم يعلم، والصلاة والسلام على نبينا محمد وعلى آله وصحبه وسلم أجمعين. السيد عميد كلية الطب المحترم الأستاذ الدكتور الزبير، السيد معاون العميد كلية الطب الشؤون العلمية الأستاذ الدكتور أحمد الحربي المحترم، السادة الزملاء والزميلات، ضيوفنا الأكارم، السلام عليكم ورحمة الله وبركاته. باسمي وباسم منتسبي فرع طب الأطفال في كلية الطب الموصل أرحب بكم أجمل الترحيب في ندوتنا السنوية، والتي دأبنا على إقامتها سنويا كتقليد لفرع طب الأطفال بالعنوان الجديد في طب الأطفال، التي أصبحت تقليدا سنويا نعتز به ومنصة نلتقي من خلالها معكم لتبادل الخبرات ومناقشة أحدث المستجدات في عالم طب الأطفال. في هذا العام دأبنا أن تكون ندوتنا تحمل في طياتها مجموعة من المواضيع التي حرصنا على تنويعها، تشمل المستجدات في الوقاية والتشخيص المبكر والحديث من العلاجات والأبحاث. أجدد الترحيب بكم وشكرا لحضوركم، ونشكر رئاسة جامعة الموصل وعمادة كلية الطب لدعمها ندوتنا هذه، وشكر خاص لكل من ساهم في تنظيم هذا اللقاء وللشركة الداعمة، والسلام عليكم ورحمة الله وبركاته.
نبدأ بفعاليات الجلسة العلمية الأولى. يتفضل رئيس الجلسة الأستاذ الدكتور جامعة.
السلام عليكم. Thank you for all attending. We begin the first session of our scientific symposium, starting with first talk given by الأستاذ الدكتور محمود الصراف, which is فيوتيسيران revolutionizing hemophilia prophylaxis. ليتفضل الأستاذ الدكتور مازن.
Drug. Starting by a word about hemostasis. Hemostasis results from a balanced procoagulant and anticoagulant pathway that generates sufficient thrombin to control bleeding. Hemophilia A and hemophilia B results from a deficiency of factor 8 and factor 9 respectively, which result in insufficient thrombin generation, which lead to bleeding. The prevalence of hemophilia: about 25 cases per 100,000 male for all severity of hemophilia A, while only 10.5 or around 10 cases of severe hemophilia A per 100,000 male at birth. While the prevalence of all severity of hemophilia B is 5 cases per 100,000 male, and only 1.5 cases for severe hemophilia B. For those born with hemophilia, the chances of living a life of normal duration and quality will be reduced by 64% in the high income countries and 77% in middle income country and up to 93% in low income country. So the early appropriate therapy and prophylaxis are the hallmark of excellent hemophilia care. The treatment of hemophilia started since 1950. They started by giving the patient blood product, blood or plasma. Then in 1960 to 1970, a plasma-derived clotting factor started to be given to the patient. In 1980s to 1990s, the recombinant clotting factor started to develop, and they give it to the patient. And in 2000, an extended half-life clotting factor are added to the treatment. While in 2010 and 2020, a novel therapy started in the form of non-factor replacement, gene therapy, gene editing, and cell therapy. The treatment of hemophilia can be divided into on-demand therapy or into prophylaxis therapy to prevent bleeding. The on-demand therapy by the patient clotting factor replacement. If the patient suffers from bleeding, hemarthrosis, trauma, so they give him, they replace him by factor 8 or factor 9 according to the equation that you know it, to stop the bleeding. Also, they may give him antifibrinolytic agent, tranexamic acid and aminocaproic acid. Another mode of treatment is fibrin sealant, which is used in during operation or in severe bleeding, which is a solution of concentrated fibrinogen and factor 13, which is combined with a solution of thrombin and calcium to form a glue, which stops the bleeding. Also, they use the DDIUP in the treatment of mild form of hemophilia A. The prophylaxis, the regular administration of hemostatic agent with the goal of preventing bleeding, and it is recommended for hemophilia management. It composed of either clotting factor replacement or by non-clotting factor A prophylaxis with clotting factor concentrate, this might give the patient with severe hemophilia clotting factor in order to rise the concentration of the deficient factor above 2%. So we will change him from severe form to a moderate form of hemophilia, and we can prevent the spontaneous hemorrhage. It is given by the factor every 2 to 3 days by using venous access, a central line, and we will get the factor at weight. But it has side effect with the frequent intravenous infusion, venous access difficulties, or thrombosis, and development of inhibitors, which will develop in 30% of patients with hemophilia A and around 10% of patients with hemophilia B. The non-clotting factor prophylaxis, first is the imicizumab, which is a monoclonal antibody, which used for hemophilia A only, with or without inhibitors. We can use it in patients with inhibitors or without inhibitors, and we used in patients since neonatal period. So it is can be used in a patient with a few days of life. The other is the fluticasone, which I will talk about it, which can be used for hemophilia A or hemophilia B, with or without inhibitors. The other is marcituzumab, which can be used for hemophilia A or B, but without inhibitors. And now gene therapy, not used now only for adults. It needs immunosuppressive medication and it is with unknown long-term safety. So, the fluticasone. In 28th of March 2025, before 10 weeks, the FDA approved fluticasone for routine prophylaxis to prevent or reduce the frequency of bleeding episodes in adult and pediatric patients 12 years old of age and above, with hemophilia A or hemophilia B, with or without factor inhibitors. The mechanism of action of fluticasone, it is a double-stranded small interference RNA, which destroys the messenger RNA and prevent the signals to form the thrombin protein. So it lowered the antithrombin activity, which this was associated with lower صور، وهذا الجسر اللي يربط حقيقة بحيرتين، واحدة بالثانية، هي مصورة جميلة جدا. الهيموفيليا تعني بالعربي الناعورية، استمرار تدفق الدم. وهذه صورة لناعور في مدينة هيد على ضفاف نهر الفرات، وشكرا جزيلا لإصغائكم.
شكرا جزيلا أستاذ مازن for valuable and updating subject. الآن يتفضل الأستاذ الدكتور أوس حازم subject allergic rhinitis in children.
بسم الله الرحمن الرحيم. I will speak about allergic rhinitis in children. إن شاء الله يعني يكون موضوع خفيف و it will be also useful to our colleagues. Our beloved university. We will start with the definitions. Rhinitis, as we all know, is the inflammation of the lining of the nose. Allergic rhinitis means it is an IgE-mediated immune response, usually associated with ocular symptoms. This is all known. It is usually underdiagnosed, undertreated. Up to 25% of children may experience allergic rhinitis, up to 40 in adults, which is very high percentages. Why it is important? It is important because it is diminishes the quality of life in children or in adults. It affects the school performance. It leads to many visits, use of a lot of unnecessary medications if not treated properly, and also the exacerbation of asthma, which is an important comorbidity, and we will talk about that. And the features, as you all know, features of rhinitis: sneezing, nasal congestion, itchy nose, clear, runny nose, coughing. We have also sometimes additional symptoms such as postnasal drip, itching of the palate, cough, halitosis, which is a very bad thing, mouth breather, snoring, bilateral itching of the eyes and weeping eyes. All these are known. The main precipitant for allergic rhinitis in adults and in children is the pollens, the molds, the animal hairs, and the hay. Of course, that's why it's called hay fever. How to reach a diagnosis? Of course, rhinitis may be allergic if the eyes are involved. This is very important. If we have eye involvement, this is mostly an allergic rhinitis. It will give the child the allergic salute like that. He's always trying to sniff the nose, to itch the nose, and he will have a transverse breeze over the bridge of the nose. It's very important. If he is exposed to the allergen and he develops the features, this is a trigger, and consequences of the trigger. This is also help from the diagnosis. The family history also is important here, such as the same as the diagnostic criteria of asthma. So always we have to ask about asthma in children with rhinitis and vice versa. So during examination, we may see clear secretions from the nose, swollen terminates. If you use an otoscope, you can use it. The ear inspection, sometimes we may get otitis media with diffusion. In auscultation, we may find wheezes, patient is asthmatic. Examination of the skin may reveal skin eczema. The red flags means that it is not goes with the diagnosis of allergic rhinitis. We have unilateral symptoms, severe nasal obstruction, sleep apnea. These are not features of allergic rhinitis. Under 2 years of age, just like asthma, usually we avoid diagnosis of allergic rhinitis under 2 years of age. Children with nasal polyps and those refractory to the usual medical treatment. So we have criteria for ENT referral: if there is bleeding, if there is unilateral disease, if there is crusting, which is high in the nose, if there is septal deviation, and also non-response to the usual treatment. This is important classification. It is called area classification, the allergic rhinitis and its impact on asthma. We have the intermittent and we have the persistent form of allergic rhinitis. Allergic rhinitis is intermittent if it is lasts less than 4 days per week, or if it is lasts less than 1 month, and it is persistent if it is lasts more than 4 days per week, or if it is lasts more than 1 month. So this is called persistent. Each of them may be mild, may be severe, depending on the affection about the sleep, the daily activity, the school attendance. So this is very important classification. This replaces the old classification, the seasonal or the perennial. When we were students, this was the allergic features of the nose. So with the increasing age, these features will become more prominent. So the younger, the less prominent the features. What matters for us as a pediatrician is asthma. Asthma is very common in our community and all over the world. 90% of asthmatic patients have allergic rhinitis. So we have to treat the allergic rhinitis. Why? Because 80% reduction in the admission to the emergency department will be noticed if we treat allergic rhinitis properly. Admission for asthma acute exacerbation. Okay? So this is very important. The investigations, either trial of steroid
or histologic pediatric acute onset neuropsychiatric syndrome. تفضل دكتور.
شكرا استاذ بيكان. السلام عليكم جميعا. Thank you all for attending this nice, interesting symposium. Today I will talk to a little bit an important and interesting subject, which it is new for some of you, and it is maybe unknown for other person who has interest in neuropsychiatry, which is pediatric acute onset neuropsychiatric syndrome. حقيقة المقالة مقتبسة من مجلة pediatric, which is well known, 2025. المقالة حديثة جدا. I interest for this subject when I face a patient as a case scenario, which is a 5-year-old boy brought to our clinic presented with a sudden onset of obsessive compulsive behavior, including repetitive hand washing and shaking. He also displays significant irritability and emotional outburst. His parent mentioned only he has a history of previous sore throat 2 weeks ago. This scenario, which is the following feature, would strongly suggest pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection as a subset of pediatric acute neuropsychiatric syndrome. هل هو presence of irritability, emotional outburst, or recent history of sore throat and onset of OCD? Child is age of 6 years, presence of repetitive hand washing and shaking rituals, or sudden increase in obsessive compulsive disorder. حقيقة الجواب الصحيح هو B. Recent history of sore throat and onset of OCD symptoms. هي الفكرة أنه الأوتوإميون association between group A beta hemolytic streptococcal infection and sudden onset of this obsessive compulsive disorder. Introduction. The sudden onset of severe behavior and neuropsychiatric syndromes in children is a frightening and potentially life-changing situation. حقيقة الأهل يخافون يجون الدكتور هذا فجأة ما بين شيء صار عنده هاي قام يغسل يدينه كثرة واحد هذا يخاف من الجيرمز هاي النظري أو بدأ food refusal يصير عنده. The pediatric clinician to whom family turn need a guidance. يعني المشكلة دول يجون ضايعين بين الأطفال وبين neuropsychiatric. يحتاجون for guidance for diagnosis and treating of this new onset of neuropsychiatric syndrome. The patient next need also expert counsel about whether these symptoms are indicated diagnosis compatible with pediatric neuropsychiatric symptoms or other things. And it could be a psychiatric or could be this acute onset neuropsychiatric syndrome. The cause of PANS is unknown, but it's theorized to be a trigger in some cases by recent infection or autoimmune issue. بس حاليا هذا الاوتوimmune issue هي مشكلة لنا عن نواجهها حاليا. Similar to the Korea, autoimmune encephalitis or even Guillain-Barré syndrome. يعني هو حال Guillain-Barré syndrome. يعني يصير عنده infection followed by this acute neuropsychiatric syndrome. هاي Korea, Guillain-Barré هذا neuropsychiatric syndrome. طبعا لازم نحن نعرف what is the normal fears. يعني كل طفل عنده وقت من حياته عنده normal fears. يعني مثل بالانفنسي عندنا stranger shyness و separation from يعني fear from separation هاي أول 3 سنين من عمر الطفل. من from 3 years to 6 years عند الطفل يخاف من الثندرز أصوات الرعد, the lights, البرق, fires, water, nightmares, animals, مخلوقات خيالية هذه, dying, death of others. This is normal. From 6 to 12 years, you get fear from germs, getting ills. يعني هاي ممكن normal يجيك طفل كوليكتور هذا يخاف من هذا. This is normal. Disaster, traumatic events, harm self, others. School anxiety تبدي عند الطفل, performance anxiety. After 12 years, peer rejection, يخاف منه مثلا, يخاف من الجماعات ويخرجون منه. هالشغلات هاي standard. This is normal يعني behavior. Or free from negative evaluation. الحقيقة البيدياتريك اوتوميون نيوروسايكاتريكس هو موضوع قديم من 1998 was based on observation clinical case study by Susan Swedo إيطال وجماعتها National Institute Health. ويعني عرفوا اللي هو البانداز اللي هو يعني some sudden onset of severe neuropsychiatric syndromes in form of OCD or food refusal following infection.
Subject cardiac complications in pediatric chronic kidney disease.
Assalamu alaikum.
Our subject is cardiac complication in pediatric kidney disease, chronic kidney disease. So as an introduction of chronic kidney disease in children is a lifelong condition, so characterized by gradual loss of kidney function. So it is must be deals as diabetes mellitus and hypertension as for cardiovascular risk factor. We have many causes like congenital anomaly, genetic disorder, acquired also disease. So early detection is crucial for managing and progression of complication. We have this stage of chronic kidney disease, normal GFR, mild, moderate, severe, and end-stage renal disease in stage 5. Estimate of the cardiovascular complication mortality in children and young adults who develop end-stage renal disease in children in childhood is 1,000 times more than normal population, with 30 to 50% of all deaths of this population attributed to cardiovascular causes. So the cardiovascular cause is cardiovascular disease is a silent killer in patients of chronic kidney disease. However, the cardiovascular cause of mortality is different from adult than from child. From the child, most common cause of cardiac problem in chronic kidney disease are valvular disease, arrhythmia, and cardiomyopathy, while in adult, most likely cause are congestive heart failure and coronary artery disease. Even though the transplantation get better cardiovascular complication, but it not end it. So in transplant, if there is failure of transplant, there is 45% of graft failure develop death from the cardiovascular disorder. Risk factor, we have a traditional risk factor like hypertension, dyslipidemia, obesity, and insulin resistance. And we have cardiovascular chronic kidney disease related risk factor like anemia, proteinuria, hyperphosphatemia, and increase in the calcium and phosphate product. This is the cardiovascular complication in patients with chronic kidney disease or child with chronic kidney disease. We have left ventricular hypertrophy, left systolic diastolic dysfunction, increased carotid intimal medial thickening, and increased pulse wave velocity. Also coronary artery calcification. Causes of the death from dialysis, and most likely cardiac arrest by arrhythmia, cerebrovascular disease, congestive heart failure, cardiomyopathy, acute myocardial infarction, and in transplant also there is cardiovascular mortality, cardiac arrhythmia, cerebrovascular disease, acute myocardial infarction, and cardiomyopathy. The frequency of cardiovascular risk and abnormality increase with advancing CKD, with the greatest prevalence during maintenance dialysis. Despite some improvement, many of these risk factors persist after transplantation, as we mentioned. The prevalence of cardiovascular disease risk factor, hypertension, about 50% of patients with chronic kidney disease have hypertension. Also, 45% may have dyslipidemia. Other traditional risk factors like abnormal glucose metabolism and obesity, about 20% of patients of chronic kidney disease have these complications. Lastly, family history of cardiovascular risk factor. If you have family history of cardiovascular
discussion. Speakers prepare for discussion. Any question?
شكرا جزيلا على هذه الندوة الرائعة وصراحة على اختيار المواضيع الحديثة وشكرا لدعوتنا. بصراحة عندي أسئلة لمعظم المتحدثين إذا سمحتوا. بداية دكتور مازن. It's a very interesting subject and new subject. You know that it's just 10 weeks from this FDA to be approved this drug. For you as hematologist, do you recommend individually to use these drugs, taking in consideration that it can cause gallbladder disease and make gallstone and subjecting an patient with hemophilia to surgery and causing a risk factor of bleeding and causing also 10% of them to have infection. And it is mechanism is loosening the antagonist, not priming the agonist. And what is the disadvantage of giving factor 8 as our gene therapy in comparison to this therapy? There is multiple things, multiple issues circling these drugs. What's your opinion?
شكرا جزيلا للاستاذ الدكتور نشوان اللي هو دائما سباقا بالاسئله في اي ندوه او محاضره، وحقيقه احنا نفرح كثير بنسمع ملاحظات واسئلته. هو فعلا هذا الدراج approved 10 weeks ago to be used in adult and children 12 years and older. يعني سؤالك هل to recommend to use it or not?
Yes, يعني with these issues having infection.
I recommend it. انت تعرف يعني in our locality هسه الكلوتيك فاكتور يوم موجود يوم ما موجود ايش حتستعمل؟ فريش فروزن لازم يكراك بس تعرف current risk of infection viral infection and طلب وقنطع شكل الدرهم وقاية خير من قنطار علاج. إذا أنا عندي prophylactic medication approved by FDA used every 2 months to prevent a serious bleeding or a serious complication. Side effect, okay, it may cause gallbladder disease. If the patient suffers from recurrent cholecystitis, we can stop the drug if the family don't want to use it. For the thrombus risk, not in all patients. It occurs in patients if the antithrombin activity below 15%. So الجدول اللي طلعتونه we can manage the dose حسب الانتيثرومبين activity اللي موجودة عند البيشنت. ممكن I can manipulate it if it's correct or decrease the dose to reach the optimum 15 to 35% of the level of the antithrombin 3 in the circulation. You ask me to recommend, yes, I recommend to use it in our patient.
There is other
because it's an alarming thing. Every patient with Rosalax, you know that it's a very common disease. How many patients with streptococcus infection will have this disease? And second, what is the prognosis? And whether treatment is beneficial in preventing the attacks? And there is no there is many investigation to be done to exclude, because it's a diagnosis of exclusion. So we have a very wide range of investigation to do before we say that cancer.
شكرا استاذ بشمال. حقيقة هو الكرنت issue هو new for us. Even يعني textbook, I read the textbook. It is not like you simplified. It is a little bit new for us. Published last data published 2012. All these data are they do meta-analysis for diagnosis. This acute neuropsychiatric illness. The incidence of this illness, it is also not known till now. Nobody know. I face the problem. The case اللي شفته بالأول slide. This is the first time I see this case. 5 years old boy come to my clinic, presented with sudden onset of OCD, food refusal. I refer him for psychiatry. For me, I don't have information about this management of this acute neuropsychiatric illness. But it's interesting. The subject is progressing, and a lot of data has been published. And we think the next textbook will be more clarified. In the textbook it is mentioned as about 10, a small paragraph talking about this subject.
Treatment, is it preventable?
The treatment شفت الامريكان جايد لاين هو اول شيء هو لازم diagnose.
message. I will never send this excessive investigations to rule out.
As I said, third slide, normal fear in pediatrics. From 6 years to 12 years, this is area of fear from germ. بس إذا الطفل جاء قبل هالاريا أو بعد الاريا جاك فجأة ما بينشوف كليريا ما عنده مشكلة الطفل. سايكولوجيكلي نورمال بس جته هاي الحالة لما جت صعد OCD وتكس لازم search for underlying cause.
I think it's still the psychological trauma because of facing doctors, facing punishment. I think he's as if he is punished by doctors or nurses during receiving treatment, criticized by family because you did something. You have